So it's great to be here and have an opportunity to talk about the field of castration-resistant prostate cancer and its molecular evolution over time, which I think is one of the key facets of how we approach this disease from a translational perspective. Ready? Go ahead. All right, good. All right. There's that and that. Good. Okay, so I've decided to call my talk The Molecular Evolution of Prostate Cancer, Trying to Hit a Moving Target. And that's because we are developing therapies around the idea of how this disease evolves over time under the challenge of castration resistance. These are my disclosures, very few of which have any real relevance to the content of today's talk. So keep in mind as I give this talk that I am a clinician. No, I'm just going to probably not need it. Okay, sounds good. So I'll just keep on this. Keep in mind that I'm a clinician, and so my perspective on looking at issues like the molecular evolution of this disease rally around really what can we do therapeutically for patients, how can we identify these changes, and how can we make a difference for patients. So for those of you who don't see this disease on a daily basis or don't quite have a full grasp of the longitude of prostate cancer, keep in mind that for this disease to become lethal, two events need to happen. The first event is castration resistance, which is progression of the disease, which here I show on the left graph in the form of a rising PSA despite a suppressed testosterone. So most men who present with metastatic prostate cancer, for example, will go on androgen deprivation therapy. This will lower their testosterone level by 90%, which we can maintain for many, many years. That's a whole subject that's also very interesting. And this can control the disease for up to many years. But ultimately, adaptive mechanisms kick in. The PSA rises, the disease progresses, and that's what we call CRPC, or castration-resistant disease. So that's event number one. And event number two is metastasis. Typically, men who die of this disease die of an overwhelming burden of bony metastatic disease, and in some cases, visceral metastatic disease, liver metastasis, those types of things. But really, you rarely see a patient without these two events happening, developing a clinically significant lethal form of the disease. So as we think about those two events happening in concert, one of the other key events and the other key observations that has occurred over the last decade or so is that there is an evolution that occurs. There is a change in the phenotype of the disease as it goes from the primary in the prostate to the metastatic lesion in the bone or the liver or the lymph node or the lung. All right? And the paper I'm showing here and others like it have done very elegant genomic work and others and have identified distinct subclones that have emerged, for example, as metastasis to metastasis evolution, or metastasis to metastasis spread, as opposed to all being primary to the metastatic spread. An ongoing clinical question in many solid tumors in oncology, including prostate cancer, is whether or not control of a primary tumor, even in the face of metastatic disease, is of any clinical benefit. And many of us, including myself, are skeptical of this question and the resources being applied to it because of observations like this, that it's really metastasis A that seeds metastasis B, and metastasis A will be different from the primary tumor in the prostate. There are also observations like this one, which is one patient and the molecular evolution, the progression of his cancer taken from the primary prostate tumor in the upper left. You see various different molecular abnormalities in the primary. You can see that as they did, I think it's 8 different primary tumor biopsy sites, there were some that had PTEN loss, TP53 alterations, SPOP alterations, etc., and others that were cancerous but did not, in fact, include those alterations. But when the metastases were biopsied in this patient, as you can see at the M5, M38, I'm sorry, at the B1 space here, when this patient underwent a metastatic biopsy, additional alterations had been acquired. And then when this patient died of his disease and was part of a rapid autopsy program and underwent a harvesting of a number of tumor sites, there were yet more alterations that were seen, or those alterations that were seen in the metastasis were preserved in the metastatic lesions that killed him. So this is a disease that evolves, unlike many other solid tumors, most notably non-small cell lung cancer. This is a disease that evolves molecularly as it progresses under treatment. So what do we do about this entity as clinicians? And so I call this the moving targets of prostate cancer. And some of these mechanisms are, in fact, targetable. We are making some progress in the advancement of new therapies for patients with prostate cancer. And I've decided to just highlight 4 of them that I think are sort of the headlines, if you will, of this molecular evolution and of the areas where we're able to really identify how this disease changes and what we can do about it as clinicians. So if we're going to talk about prostate cancer and we're going to talk about its lethality and we're going to talk about its evolution and adaptation over time, we have to really start that story with the androgen receptor. The androgen receptor is a fascinating molecule, really, from an evolutionary perspective and from a number of other perspectives because of its persistence. It's amazing that after 75 years of trying to suppress the androgen receptor in prostate cancer, it's the molecule that keeps winning. And we have new drugs that we develop that work and can put the disease into remission for a period of time. But ultimately, what we see is that when most of these men who die of prostate cancer succumb to their disease, what we are seeing is high PSAs, active androgen receptors that are doing a high degree of signaling. And so there are a number of these different events and adaptational processes that occur. And this is a very bad picture that I put together when I wrote a review paper with Scott Dame's old mentor, Don Tyndall, several years ago, because of the cartoonish nature on the lower right and then this weird-shaped adrenal gland on the top. But anyway, I think it gets the point across that you can have all kinds of adaptations that occur, whether they be ability to increase androgen production or to increase the actual number of the androgen receptors through androgen receptor amplification and other adaptations that I will touch on. So this is actually a very important event because it's something that we can target and we need to talk to our patients about. And when I talk to patients, I like to use analogies that helps them understand their disease. And so several years ago, I started talking about why we use various hormonal therapies when treating a disease that had been previously called hormone-resistant prostate cancer, because that seemed to be illogical. And of course, I understand logic because I was a philosophy major. So I call this the Prius effect. And what I say is, consider a situation where gasoline is $1 a gallon. It's very cheap. There's plentiful fuel for our cars. People don't really care about fuel mileage. They go out and they buy SUVs and pickups and Hummers and those types of things. But as fuel becomes scarce and the price of fuel goes up, the vehicles that come out of Detroit and Japan and other places have to become not only more fuel efficient, but if they can adapt other mechanisms to fuel the car, that would be useful too. And so this is what we see vis-a-vis the androgen receptor in castration-resistant prostate cancer. Androgen receptor expression increases, fuel efficiency I call that, as does intratumoral and other areas of androgen production. So it really becomes there really becomes a battery almost inside that cancer. And so this is, won't go through the complicated pathways on the left, but that's the androgen, steroid receptor expression, steroid receptor synthesis pathways, which are common to estrogen, progesterone, and to androgens. And what the group at the University of Washington did is looked at benign prostates, localized prostate cancer, and metastatic castration-resistant prostate cancer tumors. And several of the enzymes associated with androgen production and conversion of androgen precursors go up as the disease progresses. So this is sort of that battery effect where it's beginning to make, or we're seeing the selection pressure for a tumor type that is able to produce its own androgens. There are now a number of studies, I'll highlight 2 of them in these pictures here, that show as the disease becomes AIPCA, which is an old term, androgen-independent prostate cancer, androgen expression levels go up. Here we see an immunohistochemistry stain showing high levels of androgen receptor in patients who had their prostates in place and had them surgically resected in the face of advanced disease. So this is a really important observation. Interestingly, these important observations kind of occurred not before the clinical trials of new androgen receptor targeted therapies began, and that didn't really drive them, but they really supported them. And so what we saw was a situation where we had two different classes of drugs that were being developed to target this mechanism. One of them is called abiraterone, which targets androgen production. It inhibits the CYP17 enzyme, which is a critical enzyme for the conversion of steroid precursors into androgens or estrogens. And the other one is enzalutamide, which is an androgen receptor antagonist. Now, androgen receptor antagonists have been around since the 1970s, but they've been very weak and they've been troubled by partial agonist activity. So they had never really demonstrated a survival benefit. And it was Charles Sawyers, who's now at Memorial Sloan Kettering, but was at UCLA previously, whose lab developed not one but two novel androgen receptor antagonists, enzalutamide, and the other one is called apalutamide, that really specifically were shown to have a high degree of activity in the context of the amplified androgen receptor. And that's the key point about enzalutamide. Abiraterone is a very simple sort of concept, really. It's a progesterone mimic. I should say a progesterone derivative that has been shown to inhibit the CYP17 enzyme. So I was actually very fortunate to be in the right place at the right time, because when I was an assistant professor at UCSF in my second year on faculty, I was given the opportunity to start a phase 1 trial with abiraterone, which at that time had a number and not a name. And it was because I had identified androgen receptor signaling as something that I wanted to target clinically. And so we did the phase 1 study, UCSF and Dana-Farber, and that was published in the JCO and showed high degrees of clinical activity. And we then rapidly turned that into a phase 2 study, and we chose to study it in patients who had not yet received chemotherapy, because it's a long story on chemotherapy and prostate cancer, but for the most part, men with prostate cancer are older, they have other things going on health-wise, and they don't want to receive chemotherapy, and it's not altogether that effective anyway. And so we studied it in a chemotherapy-naive patient population and saw that 70% of the patients benefited from this approach. Then we went into a phase 3 study, which actually was the graph that I showed you on the previous slide, which was published in the New England Journal of Medicine and changed the standard of care for prostate cancer. So that was a good run that I had that ended in around 2012. And it was fortuitous timing because of this data showing that androgen receptor expression goes up in prostate cancer, androgen synthesis goes up in prostate cancer. And we continue to develop that drug, and it's used all over the world. There are new drugs, such as this one that Dr. Gupta just published, which is a combination AR and CYP17 antagonist. The question remains as to whether or not new therapies will supplant enzalutamide and abiraterone, both of which have side effects that I'm not going to go into in great detail. But I think it's encouraging, and I was very happy to see this paper emerge from Shilpa from a study that she had led, developing a new CYP17 inhibitor. And so I want to highlight her work and work being done here that will hopefully take this on to the next generation. So the question is, can we improve on these AR-directed therapies when resistance develops? Because while 70% of patients will quote-unquote respond to this therapy, meaning their PSA will go down and their tumors will shrink, this response will last for anywhere from 12 to 16 to 18 months, except for in the outliers where the responses can last for 38, 48 months. And in fact, we have some patients on one of the trials that I led who are now out 48 months and have PSAs that have gone undetectable. And we're beginning to wonder if there is an outlier group who may in fact be cured by this approach. And we're exploring the possibility of discontinuing therapy and seeing what happens to them. But those are rare patients. For the most part, patients experience transient responses, pain goes away, tumors shrink, that's all good, but resistance develops and they still die of the disease. And so we've looked at a number of different approaches. PI3 kinase is an approach that was all the rage back in about 2012. We thought we had a lot of different papers coming out showing that PI3 kinase activation is the key mechanism to overcome AR inhibition. We did a few trials at UCSF looking at PI3 kinase inhibitors, and so far there has not been a lot of activity there. For those who follow this space, There is a drug currently in trials that targets AKT, which may have some activity, but PI3 kinase has been relatively ineffective. I'm going to talk about AR aberrations a little bit, which is a commonly discussed entity in the AR world, again, causing challenges from the clinical research perspective. And I'm not going to talk about it in too much detail, but I will highlight that Arpit Rao, who's sitting over here, is going to be doing a couple of studies, both in the preclinical and clinical work, looking at targeting CDK46, which may be a pathway that we can target in patients who have disease that is resistant to the androgen receptor-directed therapies. So I'm sitting here in front of Scott Dame, who's really one of the world's experts on AR rearrangements and AR aberrations that occur in prostate cancer as the disease evolves. But the one that has created the most drama in our world is AR-V7. So for those of you who think about steroid receptors, you will know that steroid receptors have a number of different domains, but really for the meat of it comes from two different domains. The domain that binds to the ligand binding domain, and the domain that binds to DNA that causes all the signaling. And so you really need both of those connected to activate the androgen receptor, the estrogen receptor, whatever receptor it would be. So it has been noted over the course of treatment-mediated selection pressure that aberrations of the androgen receptor can occur. And the one that was most notable in the literature was this one called the AR-V7. And this is a variation that has a DNA binding domain, but it does not have a ligand binding domain. So it's sort of like an automaton androgen receptor that will signal and bind to DNA and do its thing, even without the presence of androgen or any other steroid hormone. And so that, you could imagine, could be a problem if you're trying to develop a drug that targets the androgen signaling, because who cares if this is an autonomously signaling androgen receptor. It's not going to matter much how much androgen is present, nor is it going to care too much about the presence of an androgen receptor ligand binding domain inhibitor, which is what enzalutamide is and apalutamide is. And so this is likely a real part of the resistance to androgen receptor targeted therapies in prostate cancer. Whether it is the only or the key driver, we don't really know. We also are suffering from a molecular diagnostic problem here, in that we clinicians are not able to, on a reliable basis, test patients for this variant and know that this is the key driver of resistance. But suffice it to say, the early data that came out with this, which is actually published in the New England Journal of Medicine, said that if you harbor a tumor that has this AR-V7 variant, you will not respond to either abiraterone or enzalutamide for the reasons that I just stated. So the question is, can we target the N-terminus domain, which is the the other business end of the androgen receptor? And there was a lot of excitement about this drug, well, first it was called EPI-001, and then it didn't work, and then it was EPI-002, and I don't know how they got up to EPI-506. I don't think it was 506 molecules, but it took a long time for this molecule to actually get into the clinic. And the thing that made it so different is that this is totally unlike every other androgen receptor antagonist that we use, and totally unlike the steroid design of an abiraterone, for example, because it was binding to a totally different part of the androgen receptor, the N-terminus domain. And I think this preclinical work was ongoing in like 2004, 2005. I don't think this drug got into the clinic until about 2012 or something like that. And we didn't see any clinical data until, 2 years ago, 2016. And what we saw was some very early signs that actually targeting the N-terminus domain may actually cause modest declines in PSA in some patients. And this is a challenging area. This was a high dose. Patients had to take over 1 gram of this drug. These were all patients who had disease that was resistant to abiraterone and enzalutamide. But this is mildly encouraging that we may be able to move the dial a little bit by targeting the N-terminus domain. But on the other hand, it's a little bit depressing because we thought that by suppressing the androgen receptor even further, we would get some mileage. So I remained a bit of a skeptic about targeting the N-terminus domain, in part because of the pharmacology of the drugs that are required to do it. It's just not a simple story like taking a progesterone derivative, abiraterone, and applying it early on like we did in our early trials. So we want to watch this space and see what happens. There are a couple of other variations of this drug that are in the clinic, but targeting the N-terminal domain remains out there as a question. I alluded earlier to CDK4/6, and I'm not going to talk too much about this at this time. This is an emerging area in breast cancer where there are a couple of CDK4/6 inhibitors that are FDA approved and in standard use. They're typically used with aromatase inhibitors and are sort of, if you want to think of them this way, they're sort of a new layer on top of the hormone signaling pathway. It's sort of a targeted therapy plus hormone therapy pathway. So this may apply to prostate cancer as well. Arpad, as I said, is diving in. This is a major part of his career development clinical trials, and I think we're going to have, before the end of this year, we should have 3 clinical trials that are using CDK4/6 inhibitors in prostate cancer. And one of the key aspects of CDK4/6 inhibition is that you need to have an intact RB. And this is another story that's evolving in prostate cancer, which is that RB loss occurs as the disease develops. I should say as the disease progresses. Our ability to target this approach will be dependent, I think, on our ability to identify patients who have RB loss or an intact RB. So this is a space we want to watch. It's very exciting. We're going to be doing some of these trials here at the University of Minnesota. So I'm going to leave the androgen receptor. We could talk all day about the androgen receptor, but I want to talk about some of these other targets that we are attempting to hit, these movable targets. The second one I want to talk about is microsatellite instability, which is, for those watching cancer in general over the last few years, this has become a big deal, not because it's a very common event, but because knowing that it is there is important. Let me highlight a patient of mine. This is a PSA graph, and so high PSA is a bad thing if you have metastatic prostate cancer. This is a patient of mine from San Francisco who is in his late 60s, had his prostate removed, and then his PSA rose, and then he showed up with metastatic disease. I treated him according to the standard of care, which is I put him on androgen deprivation therapy. I gave him 6 cycles of chemotherapy, which is known to improve survival. His PSA went down, and then he enters the left side of this graph. And his PSA was undetectable, but very early on, within a year or so, his PSA began to rise. So I did sort of the standard stuff that we do in prostate cancer, which is treat him with abiraterone. His PSA hardly went down, and then it went up. He was developing more bone metastases. He was actually starting to lose weight. I think he lost about 20 or 30 pounds. He had been a very active guy, traveled the world, doing all kinds of things. And finally, I put him on a treatment called radium, which is kind of a palliative treatment. It does improve survival a little bit, but it wasn't really helping all that much. And finally, I was sort of seeing him kind of dwindle in front of me. And so because of some new data that was coming up, I sequenced his primary tumor, which had been removed from him, I think in 2000, his prostate, which had been removed in about 2012. This was in 2017 when I did this. And on the basis of those sequencing results, I started him on immunotherapy. And so here is a copy of his report from our tumor sequencing that was done. He had a pathogenic mutation with a mutant allele frequency of about 63% of the MSH2 gene. And this is a really important observation because what happened here is that he has a microsatellite instability in his prostate cancer. This essentially creates a loss of, it creates a situation where the disease becomes hypermutated. And when a disease becomes hypermutated, there become a lot of neoantigens are developed. And so when there are all these neoantigens out there, the patient's own immune system begins to notice these immune antigens and tries to mount, but is only weakly able to mount an immune response. And so with the new immunotherapies that we use, essentially what we're doing is we're turning off the brakes on the T cells that are inhibited and unable to really mount a full immune response against the neoantigens. And you can see that his PSA dropped from this point. I gave him one dose. His PSA was at the beginning, it was 170 something. He was having pain, he was losing weight. After one dose, his PSA dropped to 20. After 2 doses, his PSA dropped to under 4. And after I think it was 4 or 5 doses, his PSA became undetectable. We treated him for 6 months, and his PSA stayed at 0. He had no side effects from the treatment, I basically took credit and moved to Minnesota. but I've kept in touch with him, and he's now off therapy, gained his weight back, no pain, traveling the world. It's one of these, success stories that we oncologists all like to talk about. And, I wouldn't have known about pembrolizumab. Pembrolizumab didn't exist 5 years ago. I wouldn't have really understood MSI high status or microsatellite instability 4 or 5 years ago, other than to know that it's a board's question about colon cancer. But it actually applies to prostate cancer, and it applies to 3 to 5% of cases. All right, so this was in this patient's primary tumor. Remember that I went ahead and I had sequenced his prostate, and that was an important event in his life and in his treatment. But the availability of pembrolizumab to treat this MSI high prostate cancer was granted through a very unique mechanism from the FDA. Pembrolizumab is the only drug, I think it's still the only drug, that was approved by the FDA without a specific organ disease indication. It's not approved for breast cancer or prostate cancer or lung cancer. It's approved for MSI high cancers of whatever origin. And that event occurred, I think it was in 2007, when the date was, 2017 rather. But the availability of the sequencing from his primary tumor and the availability of the immunotherapy is the reason that this person is alive today. And so I want to highlight the fact that this was somebody's primary tumor that had this MSH2 mutation. I've seen a couple of others who have had sort of similar stories. But there was just a paper this past week or 2 weeks ago in JAMA Oncology from Wasim Abida and their group at Memorial Sloan Kettering, where they took all of their sequencing data from all of their patients and they looked at the MSI high patients that they had, and I think they had sequenced a few thousand, and they had something like 46 or so MSI high cases. And as one would predict, not everybody has these amazing complete responses, but many patients do have very, very good responses to immunotherapy. So it's become a standard approach. However, the observation that I took from this paper that was just published December 27th was that 2 of the 6, so they only have these 2 of the 6 MSI high tumors were confirmed as acquired somatic mutations. Okay, so these were not in this patient's primary tumor, and the Memorial Sloan Kettering group and others have been biopsying metastatic tumors, just like that case I showed you in the beginning of the person who ends up having the autopsy, and we look at all the different alterations. If they had, in those 2 cases, not done a repeat biopsy and not continued to ask questions of the tumor, this patient would not have been able to receive this immunotherapy. So that's a critical observation, not specific to prostate cancer really, but this idea of treatment-mediated selection pressure is a key one in prostate cancer. So this highlights the fact that multiple subtypes of this disease are emergent, and we should not any longer, and most of us don't, think of this as a uniform entity that is hormone-sensitive, hormone-resistant, lethal. It's actually dividing out into all kinds of different pathways, of one of which is MSI high status. So now, and I'll highlight this again, now we clinicians are faced with the challenge of querying the biology of the tumor as we treat it. And it used to be that we would use the available therapies based on side effects, based on age, based on availability, et cetera. But now we really need to know what the biology is. And so now if we're treating a patient with castration-resistant prostate cancer and we don't know his MSI status, I think we have good justification that we should go in and biopsy that tumor and try to get that tissue and try to get it sequenced because it'll make a difference for that patient. That is really a lot easier said than done because, as I said in the beginning, most of the patients with lethal prostate cancer who we are seeing in our clinics as oncologists have bone-only disease. And so to get a tumor out of a bone, to get good DNA, to get RNA is a totally different story. But to get enough tissue to sequence, you have to decalcify the bone. You have to know where in the tumor you want to do the biopsy. Because if you just stick a needle in the middle of a bone metastasis, you're going to get necrosis, and you're not going to get much viable tissue. And so there's really an art that's emerging in terms of how to biopsy bony metastases, and I'll talk about that in a second. Because that led to another observation, another target that we're seeing emerge, which is neuroendocrine or small cell aggressive variant prostate cancer. So we've long known that there are subtypes of patients with prostate cancer who will have a high degree of, let's say, liver metastasis. That it would progress very rapidly. The existing therapies won't work. And we've also known that there is this thing called small cell prostate cancer. Now, maybe once a year, maybe once every 2 years, I will see a patient who's diagnosed with what we call de novo small cell. He's never had sort of the typical high PSA prostate cancer, but he gets a really big prostate or he gets metastatic disease and they biopsy it and they see small round blue cells, okay? This disease under the microscope is pretty much the same as small cell lung cancer, that's right, and is treated pretty much the same way. But unlike lung cancer, or mostly unlike lung cancer, there is a version of prostate cancer that is small cell that emerges under, again, the treatment-mediated selection pressure of standard hormonal therapy. And so this is sort of the difference. There's treatment-emergent, or what we call T small cell neuroendocrine cancer, or de novo small cell neuroendocrine cancer. And the treatment-emergent small cell differentiation, we think, is going to become more prevalent as we get better and better therapies. Because as we squeeze the disease tighter and tighter with drugs like abiraterone and enzalutamide, chemotherapy, and even immunotherapy, what we may do is potentiate the development of these neuroendocrine phenotypes. So this gets to this other sort of issue, is that there has been a sort of an understanding over the past couple of decades that, that while small cell prostate cancer exists, it is considered to be almost mutually exclusive with the typical AR-driven prostate cancer. And so this is data from the University of Washington's rapid autopsy program, where they took out, I think the number here is they have 170, about 300 tumors from about 86 patients. And in the green, you see the number of patients, meaning the number of patients whose tumors they looked at, and then the number of tumors that were AR positive. And then over time, we see the number of tumors that become AR negative and neuroendocrine positive. And so you can see in the 1998 to 2011 era, this was before we had all these new therapies that we could use. The AR negative neuroendocrine was about 10%. The neuroendocrine, there's this other entity, the AR negative, neuroendocrine negative, that emerged from 5% to 21%. So there's some type of an evolution going on here, and there's a skew towards losing AR signaling as neuroendocrine differentiation develops. This is a slide I got from Misha Beltran, who's at Dana-Farber now, and she did a ton of this great work at Cornell, where she looked at the CRPC adenocarcinoma, AR signaling, AR signal, if you will, and the CRPC neuroendocrine carcinomas, and found a lower average AR signal. So this was sort of the dogma that has been sort of developed, even though this is relatively recent data, that there are some cases where the AR is just sort of turned off. It's neuroendocrine. We can't use the hormones. We have to use chemotherapy, and it's a very different thing. But we didn't have all these questions, and so I was part of a big, great moment, if you will, in team science out at UCSF of all the sites along the West Coast, and we received funding from the Stand Up to Cancer and the Prostate Cancer Foundation with a specific goal of going in and biopsying up to 300 metastatic prostate tumors. And we were able to accomplish that. This is data that was recently published in the Journal of Clinical Oncology by Rahul Agarwal, who's a faculty out there. And in this setting, we did 249 biopsies of living patients, not rapid autopsy, patients with bone, lymph node, liver, and soft tissue metastases who had undergone treatment with abiraterone, enzalutamide, and even in some cases chemotherapy. And what we see is that the incidence of treatment-emergent small cell neuroendocrine cancer was actually striking at 17%. And de novo small cell cancer, the kind that I see once or twice a year, is, once or twice a year, once every 1 or 2 years, which puts it at less than probably 1% of all cases. So the fact that we're seeing this in 1 of 6 men with prostate cancer who have been treated is actually an important phenomenon. And as I'll show you, we're beginning to get a handle on what this phenomenon is all about. There was a lot of work done looking at genomic sequencing and RNA sequencing in these tumors. And sequencing analysis demonstrated that using unsupervised approaches, unsupervised transcriptional profiling, was able to pull out a difference in these small cell neuroendocrine tumors that emerged under treatment guidance, under treatment selection. That the treatment-emergent small cell neuroendocrine cancer is associated with a poorer overall survival, as one would expect, and this is consistent with our clinical observations over the course of many, many years. So we got a sense on this phenomenon, and in fact, our clinical guidelines that we follow, the most commonly used ones are the NCCN, the National Comprehensive Cancer Network Guidelines, actually created for the first time sort of a new small cell pathway, if you will, which is a depressing one more or less, because it basically says, not much of what you're going to do is going to work, because the standard hormonal approaches to prostate cancer typically don't really apply. We've learned a few other things about this entity. Small cell neuroendocrine cancer is associated with a high PSA, which is interesting because the de novo small cell cancers, people will have negative PSAs, 0 PSAs. But here we're seeing this entity that we always thought didn't have the androgen receptor and didn't make PSA, that the average PSA is over 50. We also thought that it was associated with things like liver metastasis, but it wasn't so much. It was seen in regular old bone metastatic prostate cancer. And here we did AR nuclear staining and found that the presence of androgen receptor in the small cell neuroendocrine phenotype is actually about the same as it is in regular non-small cell prostate cancer. Okay, that was an important observation, but that the androgen receptor is there, but its signaling is kind of turned off. All right, so the term that's emerging, I'm not sure I love it and whether it'll stick, but it's called AR indifference. So what is signaling in here? And it still remains to be seen and to be validated, but ongoing work is looking at sort of this master regulator analysis. And Rahul's work, which was recently published, identified PDX1 as a novel putative driver here. This is essentially based on the actual expression of this pathway in the neuroendocrine tumor compared to what is expected or to what is seen in non-neuroendocrine or non-small cell prostate cancer. Now, whether we can use that as a therapeutic target or drive this remains to be seen. But there are lots of analyses going on right now that look at this. And we're worried about the fact that as we develop newer and newer therapies, this entity is going to become more and more common. And so this is something that we see now. I have it here in the pie chart, and that the piece of the pie may actually get bigger over time. So we need to keep our eyes on not only what is small cell neuroendocrine prostate cancer, but what are the key molecular drivers of it, and as importantly, are there any potential therapeutics for those drivers? So my fourth target, I'm going to take a sip of water, is one that is probably receiving the most attention right now in terms of therapeutics, because there are therapies out there that target this mechanism, and we just need to get them validated more or less in prostate cancer. So that's DNA repair. And most of you know probably something about DNA repair, but I'll just give you the lowdown on the prostate cancer world. So in the genomic landscape of prostate cancer, this was a key paper back in 2005. We're looking at a number of primary prostate tumors and doing genomic analysis and looking at various different pathways, it was identified that about 20 to 25% of metastatic castration-resistant prostate cancers will harbor some type of DNA repair alteration. The most common is BRCA2. BRCA1 is less common, like 2%. ATM is the second most common one, occurring in about 7.3% of cases. And so this is an interesting story that's evolving. There are, of course, a number of mediators of DNA repair. And I'm not going to talk so much about the mechanism of DNA repair alterations, but the fact that there are a number of genes. And in fact, as you'll see, there are maybe upwards of 15 or 16 or so genes that are associated with DNA repair in prostate cancer. We have taken to using the term DDR, defective DNA repair, because it encompasses a whole family of defects, not simply homologous recombination deficiency. However, a lot of people in the field kind of use these terms back and forth, and so I might even slip and say, for example, HRD when I'm referring to a BRCA2 mutation, which is not technically true, and we should be using a more general term called defective DNA repair as we think about this. But the key for those of you who aren't exposed to this very much is that in the setting of defective DNA repair, when DNA undergoes double-strand breaks, a normal cell will replace it by homologous recombination. But if you are an HRD, homologous recombination defective cancer cell, you are unable to do that. But PARP is an enzyme that is actually able to do this. Now, if you have a PARP-inhibited cancer cell, this is a situation where DNA damage accumulates and the cell will die. So when I explain this to patients, I basically say, you know, the PARP is like the backup system for repairing DNA. So if your cells come into it with defective DNA repair and they're, you know, tumor cells turning over quite a bit and doing a lot of DNA synthesis, unable to repair those breaks, PARP is there to do it. So if we inhibit PARP, we basically knock out the backup mechanism. Simplistic, I know, but it works and it helps me. So what we're seeing now is PARP inhibitors emerging as therapies in prostate cancer. And so we have 2 trials open here. Actually, we have 3 trials open here with PARP inhibitors in prostate cancer. One of them is Triton-2, which has been preliminarily presented. And the other one's Triton-3, which I'll talk about briefly. So Triton-2 is a study with a drug called Rucaparib that's a PARP inhibitor, orally available, pretty well tolerated. And we just saw some data emerge from this at the ESMO meeting in Munich a couple of months ago. And this is kind of what we're seeing happening in the DNA repair world in prostate cancer. We're lumping all of these mechanisms together, BRCA1, 2, BRIP1, ATM, FANK-A, et cetera. All of these patients are sort of eligible currently for trials like this one, the Triton-2. But really, as you can see, and I think the reason why these data were presented a little bit early is that there are some of these mutations that do not benefit from PARP inhibitors. So for example, the ATM mutant patients really had very little benefits in terms of PSA decline on this therapy. Whereas the BRCA1 and BRCA2, the red bars, you see many of these red bars that are downgoing, indicating declines in PSA on the PARP inhibitor. And so really it's possible that the PARP inhibitors are going to be best fit to only BRCA1 and BRCA2. So this is a phase 2 trial with no control arm, which is basically taking a whole bunch of patients with all these different mutations, applying this drug, and seeing what happens, like this waterfall plot suggests, to PSA. Okay? So the idea behind developing this trial is that if we can develop a diagnostic that says for BRCA2 mutant patients, 70% or so will experience significant declines in PSA and delays in the progression of their disease, that could get the drug approved, which would be great, because then you don't have to do placebo-controlled randomized trials, for example. And the Triton-2 study is 84 patients. I think the total sample size is about 120, compared to the typical phase 3 trial that we might do, which will have 850, 950, 1,200, 1,400 patients, whatever. And so the challenge with drug development is that if you don't have a reliable companion diagnostic, or you're not exactly sure about the actual activity of your drug, you do need to do a randomized trial, and that's what Triton-3 is. And this is a very complicated study. I am one of the 2 global PIs of this trial. It is a registration study for Rucaparib. But here what we're doing is we're taking patients who have already received abiraterone or enzalutamide, they have a BRCA1, BRCA2, or ATM-only mutation, and we're randomizing them to receive the PARP inhibitor, 2-to-1 randomization, or physician's choice of other therapy, which in most cases will be chemotherapy. Okay? And then when the patients who are on the chemotherapy develop disease progression, they'll cross over and they'll get the PARP inhibitor. So one of the challenges is we kind of know that these PARP inhibitors work and they're out there and being used. And so it's somewhat of a challenge sometimes to get patients exposed to these drugs when they can maybe get them off-label elsewhere. That's the story in the US. Fortunately, in Canada and Europe and Australia and other places where these mutations are common, it's harder to get those drugs off-label. Now, that's helping the drug development process. We could argue about whether patients would agree with that statement or not, but it'll help accelerate this trial. So this is a moving target, however, because even when we have, and this is really interesting, and this is a paper that I was a part of that came out of UCSF from David Quigley, who spoke here last summer, and Felix Feng, who also spoke here last summer, is that that BRCA2 mutant prostate cancers exposed to PARP inhibitors will undergo a process of further evolution and further selection pressure, which will result in the fixing of the mutated BRCA2, which I think is fascinating. These are reversion deletions or reversion mutations that with continued mutation, the BRCA2 gene essentially restores its open reading frame and will create a truncated yet functional BRCA2 protein. So it's a mutation that is targeted, and the resistance mechanism is that the cancer undoes the mutation. And so that's a big challenge. And so Felix Feng and myself have taken on a project of trying to develop detect the emergence of these reversion mutations as they occur under the stress of these PARP inhibitors. But then the question is, how are we going to target reversions therapeutically? And so this cartoon suggests that there's a number of mechanisms responsible for DNA repair. And what we're hoping is that we might be able to target either ATR or WEE1, which are two mechanisms in this schema that might be able to overcome this issue and enhance or restore PARP inhibitor sensitivity. So we submitted an R01 to do this. We didn't get funded. We're going back in this spring, we hope. And we're hoping that this is something that we'll be able to do. So it's a translational approach where we're going to use cell-free DNA to detect the reversion mutations, hopefully early on in their development, and subsequently target other approaches in this setting. So in the last couple minutes here, I'll talk about another very interesting space, which is DNA repair and androgen receptor kind of coming together. And one of the key knowns that's emerged over the last few years about prostate cancer is that the androgen receptor and intact androgen receptor signaling actually plays a role in supporting DNA repair. So in a way, when you take anybody and any man with prostate cancer who does not have, for example, a BRCA2 mutation, and you suppress his androgen receptor, you decrease his testosterone, he will experience a transient phase of what we might call BRCA-ness, right, where he's lost the support of the androgen receptor's ability to help aid in DNA repair. And so the thought is that if we actually hit him with that androgen receptor antagonism, and then we hit him with a PARP inhibitor, we've sort of hit two legs of the stool in terms of DNA repair. We can induce this idea where DNA may accumulate and the cells may die, and we may see improvements in outcome. So this would be great because, as I just said, BRCA2 mutations only occur in about 13% of patients, but roughly 100% of patients with newly diagnosed metastatic prostate cancer will have androgen receptor signaling, and a high degree of them, probably another 85 or 90%, when they develop castration-resistant prostate cancer, they will do so with a continued active and signaling androgen receptor. So the idea is, can we target androgen receptor and PARP together? Now, this is not an original idea to me. The Brits are ahead of us, and they did a study where they took abiraterone, hormone therapy, in castration-resistant prostate cancer and combined it with Olaparib, okay? And they did this for unselected patients for DDR. This is patients, some of them had BRCA2 mutations, some of them did not. And that's the key point. And what they found was interesting maybe not striking, but quite interesting, which was that the patients who took the PARP inhibitor, in addition to the abiraterone, had a better outcome than those who took the abiraterone alone, even those patients who did not have the BRCA2 mutation. So this is unselected patients, and it suggests that maybe we, in the future, won't have to do all this testing of the genomic mechanisms in order to identify patients for PARP inhibitor therapy. Now, the reality is patients who have BRCA2 mutations do better, right, because they are much more sensitive to the synthetic lethality that a PARP inhibitor will bring in. And so that's what the table on the bottom suggests is that a BRCA2 mutated patient who took the abiraterone plus olaparib went about twice as long until his disease progressed as the patient who took abiraterone plus placebo. But in the patients who were wild type for BRCA2, they still had a modest benefit from the PARP inhibitor. And so we noticed this, and we started thinking about this and said, well, there's probably something here. These patients in this study in the UK were using abiraterone plus olaparib, so 2 other drugs, and these were all post-chemotherapy patients. So these were patients who had fairly advanced disease. As you can see, the survivals were relatively short for these patients, and the progression-free survivals were relatively short. So I put my head together with my colleague, Dr. Rao, and we decided to think about maybe doing this in the U.S. And Dr. Arpit has come up with a phase 3 trial of co-inhibition of androgen receptor signaling and PARP inhibitor as a novel therapy in previously untreated metastatic CRPC, which has the acronym of CASPR, like the friendly ghost. And Arpit has presented this trial. It's a phase 3 trial. We're still working on a number of different facets of it. This is going through our Alliance for Clinical Trials in Oncology, which, if it's open, it'll be paid for by the NCI, so it'll be supported by the NCI. It'll be open in upwards of 220 different university and community sites. And you know, if completed and positive, could help us definitively answer that question here in the U.S. about the unselected patients who may not need to be tested for BRCA1 and BRCA2. Now, we're going to test patients because we would need to stratify the clinical trial on those findings. But that's sort of the key observation, and I'm happy to support, and we are happy to support Arpit as he goes through this process, which could be a long and arduous one, I must tell you, my friend. Because getting phase 3 trials through the NCI is, well, as my former mentor used to say, it's like the mating of elephants. I swore I would never use this analogy, but here I am. It's like the mating of elephants. It's slow, and it's painful to watch, but it results in a beautiful big baby. So anyway, so there we are. So I'm going to stop here and just say, hopefully I've given you a sense that several mechanisms and entities emerge through treatment-mediated selection pressure. And I've used that 4-word term, treatment-mediated selection pressure, a number of times. It's sort of a mantra in castration-resistant prostate cancer and something that we need to think about. I think it's possible that we're reaching the limits of AR targeting and that we have good drugs. I don't know how much better we can get, but I'm open to new data. We're beginning to make headway with precision selection of patients for trials, and I will close with the statement that all of this suggests that we need to do continued tumor assessment. We need a biopsy program here so that we can easily get both clinical grade and research grade tissue from patients who are experiencing disease progression. I think that there's a lot of headway that we can make in using circulating tumor DNA to look at some of these alterations, but of course that has limitations as well. So I've got a few minutes left. Sorry, I went over a little bit, but I'm happy to take any questions.
Oh, of course, in the back.
Thank you. That was terrific. The one area that you didn't comment on is epigenetic deregulation. There's a fair amount of evidence that there are polycomb protein deregulation that now changes the entire landscape of chromatin remodeling that also may offer therapeutic targets.
Yeah.
Would you comment on that?
I have to confess that I'm not as well versed on the clinical opportunities that arise there. However, I know that there are, and maybe Shilpa knows some, because I think you've worked a little bit on HDAC inhibitors and looking at targeting methylation in combination with other therapies. I would say that those clinical trials remain early. The other approach that I didn't comment on, but could have if I had another hour, is the bromodomain, which I think is sort of tied in with that same mechanism. Shilpa, you did a trial, phase 1 trial of a bromodomain inhibitor. Early days, I think, in that setting, because those drugs are, it's hard to know if we're getting into the therapeutic index on those. So yes, it's a clinical target. No, I didn't talk about it. It is something that we need to be thinking about, though.
Thank you. So tell us a little bit more about those neuroendocrine tumors. How fast do they grow? Are they really in the cell cycle? Are they in G0, or what's happening with them?
Yeah, good question. So I'll just tell you, sort of what we see clinically, and I'll just give you an anecdote. For example, a patient of mine years ago had a PSA mid-range, like in the 30s, lymph node metastases, but he was fine. I put him on abiraterone. His PSA goes to 0. That happens in about maybe 20% or so of patients on abiraterone. He looked great. Then he calls in. He's like, I don't feel so good. My eyes are yellow. And he comes in, and he was jaundiced, and his liver was full of cancer. We biopsied it, small cell, and he died within probably a few weeks. That's an extreme but not a crazy example. And so there's something about these patients that what we don't know is, what did he have in his primary tumor that potentiated the development of the small cell? And so we're just getting to the point where we can say, oh, we actually are seeing it in 1 out of 5 cases, and we're looking at sequencing, and we're looking at what are drivers of this. But in terms of the growth rates, these can be very rapidly growing cells. That's inadequate. Something transformed somewhere, not necessarily the liver, and the liver was the end result that killed him, not the contributing factor to the development of the neuroendocrine.
So, great talk. Do you think that PARP inhibition will synergize with other types of hormonal therapy and other types of tumors? So it should generalize? Yeah,
I think it's always safe to try to generalize. It's never safe to fully generalize. In other words, it makes sense to study this phenomenon by targeting the ER in breast cancer and PARP, but it's not. So just back up a little bit. Isn't it interesting that that the cancers that arise in patients who have BRCA2 mutations tend to be endocrine cancers? Interesting observation number 1. Interesting observation number 2 is that what we're doing in prostate cancer was done in breast cancer already. And so we're not really forging a ton of new territory here. And then, ovarian cancer is the other one, right? So you've got 3 cancers, endocrine-driven, where BRCA2 is a big player. So I think you may have answered your question by basically saying, if you look at where the PARP inhibitors are having activity, they are in the endocrine cancers. Yeah, I don't know. It's a good question.
Yeah, I have a question. So when you get the patient, when you have the primary tumor, why not do the radial prostatectomy instead of giving the ADT therapy, then leading to the CRPC and metastasis? Because when you get the prostatectomy, maybe we can save the patient from the metastasis and the CRPC then.
Yeah, so why not do it when they have... yeah, so the reality is about... I don't know, what is it, maybe 15% of the new diagnoses of prostate cancer are men who don't have the opportunity to have a prostatectomy because they already have metastatic disease. This is a very interesting moment in epidemiology because the U.S. Preventative Services Task Force a few years ago decided to downgrade the recommendation for PSA screening. So we're not screening for prostate cancer like we used to, and as a result, we're seeing more patients come in with metastatic incurable disease. Now, it's possible that those patients would have had incurable disease anyway, but they might have been caught a little bit earlier. We don't know. But that is a phenomenon that is happening. The sort of the reverse of your question is, is the primary tumor a driver of metastatic lesions? And that's an open question. There was a really interesting paper, New England Journal of Medicine in October, of a clinical trial in the UK where they actually treated the primaries of patients with low volume metastatic disease, treated them with radiation, not surgery. And those patients had an improvement in survival. So that's a phenomenon that may be telling us that prostate cancer, like most cancers, exists along a spectrum of volume, right? And so people with low volume, treat for cure, prostate surgery, radiation. Intermediate volume, including low volume metastatic disease, we might still be able to cure some people by treating the primary tumor, which is a really interesting observation. The patients who have more than 4 metastases are probably not amenable to curative therapy.
Chuck, that was a great talk. I have 2 questions. One for the small cell that you published from your cohort with Rahul.
Yeah.
That the PSA levels were median above 50. But typically in the clinic, we see that, the patient's PSA has gone down on Abi, but the scans show new lesions. That's what triggers our suspicions for. So was the PSA seen high, and was there anything specific about that cohort? Because
with
typically the small cell stops secreting.
No, that was the observation. I may have not made that clear, which was we thought it was interesting that our small cells had a median PSA of 50, because we would have hypothesized, or did hypothesize before that what we're going to see is these small cells are going to emerge in the context of a low PSA and more visceral mets. But they actually evolved in the context of regular old prostate cancer in the bone.
And the other is Logothetis work on anaplastic prostate, like patients who are refractory at the get-go. They may not have small cell features, but they are still treated with carbo or docetaxel.
Yeah, I flashed through that really quickly. So anaplastic is a term that applies, as you know, to this really clinically aggressive disease that we can't molecularly characterize. What is probably a key driver there is the triad of TP53, TP53 alteration, RB loss, and PTEN loss. I mean, RB loss is in about 45% of CRPC. PTEN loss is like 70%, and P53 is about 50%. So when somebody has all 3 of those, that tends to be an aggressive disease. Those aren't small cells necessarily. So, the question is, should we proceed by doing molecular diagnostics, and should we be splitters and develop clinical trials for the small cells and the TP53 and do that? Or should we be lumpers and say, well, anaplastic, highly aggressive disease with low PSA, let's lump them in with small cell? I think we're moving towards being splitters on this point.
Here, great talk, thank you. So I have a really quick question about therapy itself. How long after this patient are treated with therapies? You said 70% of them have tumor regression, and then 30% of them.
In some cases, yeah.
In some cases.
With abiraterone, which is the one where
what's the continuum therapy like with the drug treatment? How long after that they keep taking the drugs or the therapies? And do the CRPC patients, do they still, do treatment with the drug, and how long after that you follow up?
So one of the key points when you look at clinical trial data, especially if you're looking at a Kaplan-Meier curve, and I'm guilty of showing a few, and you see treatment and control, and you see like survival curves or PFS curves or whatever, what you're going to see is the whole patient population and how they did on average, right? But what I think your question is getting at is, when I take 100 patients who are typical CRPC patients, and let's say I put them on enzalutamide, which is a standard of care drug, 70% of them are going to have a PSA decline of 50% or greater. If you have a PSA decline of 50% or greater, you are going to live longer than the patient who does not have a PSA decline of 50% or greater. That has been shown over and over and over again. About 20% or 15% of patients on that drug are going to have a PSA decline of 90% or greater, and those patients are going to live longer than those who have only a 40 to 50%. And so this isn't really an answer about PSA, but it's about the spectrum of response to therapies. And so, when FDA approvals occur, they're basically looking at like a whole population of patients that include those who didn't respond and those who responded very, very well. And so whenever you look at those survival data, you should say, well, what was obviously there's the hazard ratio, and what is the 95% confidence interval around it, and what is the median PFS or median survival, but what's the range, right? Because of the diversity that I just got done talking about, you're going to have patients who don't respond to any therapy, and you're going to have some who respond very, very well. But when we, with novel therapies, if we're seeing a response proportion in that 50 to 70% range, and we're seeing progression-free survivals in the range of 17 to 20 months, that's actually a good thing. But this is in castration-resistant prostate cancer. When we treat patients with their initial hormonal therapy, the durations of benefit are much longer, 40, 50, 60 months. And there are patients out there right now with high burdens of metastatic disease who are enjoying a very good quality of life and PSAs of 0 because they started hormone therapy and got 6 cycles of chemotherapy a year ago that kind of put them into remission.
But do you guys stop treatment after the PSA is lower, or
we don't stop the androgen deprivation therapy. We've tried that for many years. We like to do it because patients like to do it. But the studies in which the androgen deprivation therapy was discontinued resulted in a worse survival. That's another controversial topic, but that's the short version.
Thank you.
We're running out of time. Is there any last burning question before we thank him? Okay, thanks.
Thank you.